Welcome to Masterclass in Airway Management. We will discuss the airway physiology required to understand all the complexities of airway management. Here we see a lateral neck X-ray with the soft tissues outlining the patient's airway. And here, the anterior border and the posterior border of the airway have been defined. They've been identified for you. Of particular importance, the posterior border defines the position of the pharyngeal mucosa with the pharyngeal muscles directly underneath, and the upper anterior border defines the body of the tongue. And it is at this point that the upper airway is at its narrowest. So, what do we mean by the term upper airway? Well, we can define a line that passes through the level of the vocal cords, as shown. Everything above the vocal cords is the upper airway, and everything below the vocal cords is lower airway. And this next diagram defines the extent of the upper airway in red, and the start of the lower airway in blue. The upper airway extends from the nostrils and the mouth to the larynx, and the lower airway extends from the larynx to the alveolar sacs. Look at this CT scan of the neck. The oval-shaped dark structure is the trachea, and the white arrow points to a little white halo surrounding the front and the sides of the trachea, and this is, of course, tracheal cartilage. The point of this is that the trachea and all the way down the tracheobronchial tree is very strongly reinforced with rings or plates of cartilage, meaning that in health, the lower airway is reinforced to prevent collapse. During normal breathing, this part of the tracheobronchial tree expands a little during inspiration and shrinks a little during expiration, but it is essentially held open by rigid bands of cartilage. The next CT scan shows the upper airway at the level of the tongue, and we see the airway is an entirely different shape, and we can conclude that in health, the lower airway is always held wide open by the tracheal rings, but the size and shape of the upper airway varies depending on the level above the larynx. It also varies with the phases of the respiratory cycle, and of course, from one individual to another. So in fact, upper airway caliber is determined by the muscle tone of the surrounding muscles, and muscle tone changes physically and dynamically. Airway caliber is determined by the innervation of the airway muscles by the pyramidal nervous system and extrapyramidal nervous system, and upper airway dimensions vary dramatically. In inspiration, the negative pressures generated by rapid expansion of the alveoli are transmitted to the walls of the tracheobronchial tree. Now, this has little effect on the walls of the lower airway because the cartilage structures hold it rigidly open, but negative pressure acting in the lumen of the upper airway acts on the soft tissues around it, essentially mucosa and muscle, causing a tendency for the walls of the upper airway to collapse inwards during inspiration. To prevent such collapse, the pyramidal and extrapyramidal motor systems automatically increase innervation to the muscles of the upper airway at the start of inspiration, thus increasing muscular tone, making the upper airway somewhat more rigid and less likely to collapse. We know this because this can be seen when monitoring neuronal traffic in the nerves innervating these muscles. And we can also monitor the electromyograph of these muscles, and we see dramatic increases in EMG activity in inspiration and decreases in expiration. And this phasic increase in innervation during inspiration occurs solely to resist the tendency of the negative pressures in the upper airway to cause inward collapse. When the patient is awake, and particularly during activity, the pyramidal and extrapyramidal motor systems keep the upper airway wide open to permit an adequate minute volume of respiration to meet the metabolic oxygen consumption needs. During sleep, metabolic levels are low, minute volume of respiration is decreased, and the sleeping brain exhibits diminished activity in the pyramidal and extrapyramidal systems, and the upper airway narrows. But in health, during sleep, it usually only narrows slightly. Now, examine this CT scan taken at a level closer to the base of the tongue. It shows that at this level, the upper airway is a fairly narrow cleft, and what's interesting is that it's a crescent shape. The lower airway, the trachea, is rigid and oval shaped, with a cross-sectional area of 2.86 square centimeters in the average adult. In comparison, the upper airway at the level of the back of the tongue, where it is a crescentic cleft, has a maximum diameter of 4 millimeters wide in the midline, and then it narrows as you move away from the midline. The total cross-sectional area is approximately 3 centimeters squared, but this, as I've emphasized earlier, changes from minute to minute during the patient's normal day. This is because physiologically the body cannot allow the upper airway to be a limiting factor on flow capacity for the lower airway. Now consider the situation during sleep when the patient is in the supine position. Pharyngeal muscle relaxation will allow the pharyngeal mucosa to move forwards about, for example, this is purely a guess, let's say it moves about 1 millimeter, and similarly, relaxation of the tongue muscles allows the tongue to fall backwards slightly, let's say about 1 millimeter. So, instead of the cross-section of the crescentic cleft being 4 millimeters wide at its widest point, it is now only 2 millimeters wide at its widest point. And because cross-sectional area is a square function of the width and length, this represents a dramatic decrease in cross-sectional area. So, during sleep, partial airway obstruction is common, and so snoring tends to be common. Now, interestingly, the principle of the wind instruments of the orchestra is that air flowing rapidly over a partial obstruction will generate a musical noise. Similarly, if the patient is snoring, it means that some air must be moving through the upper airway. We can appreciate that airway obstruction at the level of the bronchioles is called wheeze, and it occurs in asthma. Obstruction at the level of the larynx is termed stridor and occurs in laryngeal spasm or epiglottitis. And finally, airway obstruction at the level of the tongue causes the bovine noise we call snoring, and it is particularly loud in obstructive sleep apnea. Now, we mentioned a very important principle earlier, that when air moves over a partial obstruction, it always generates a noise. So, normal breathing is silent breathing because there is no obstruction. And when the patient is apneic, or there is 100% obstruction, the patient's breathing is also silent because there is no movement of air. And this is an incredibly important phenomena, silent breathing. It is critically important to remember that silent breathing can be entirely normal, or it may be due to apnea or due to a totally obstructed airway. When dealing with patients intraoperatively and postoperatively who have silent breathing, it is prudent for us to assume the worst case scenario and assume that the patient is either apneic or has a 100% obstructed airway until proven otherwise. So the bottom line is, beware of silent breathing. Now think about this for a moment. I stated that airway closure occurs during normal sleep in many people. Now, doesn't this strike you as strange? Doesn't it seem, after millions of years of evolution, that a major design flaw in an essential body system has been allowed to persist? Why does the upper airway tend to close when the guaranteed supply of oxygen is so vital? It seems to make no sense at all. It's perplexing. Or does it? Does it make any sense? In fact, it makes perfect sense. Just remember this. When we eat food, we chew it and then it must be swallowed. And this is the job of the pharynx. We can see immediately that the upper airway is designed to close. If it could never close, we would never be able to swallow our food. This is all because the upper airway is shared by two vital body systems, the respiratory tract and the gastrointestinal tract, and the pharynx has a dual role for both breathing when it must be kept open and swallowing when it must be allowed to close. Unfortunately, this gives rise to deaths from untreated airway closure in head injury and intoxications, etc., and it can cause death from accidental choking during meals. The airway above the larynx is soft tissue, and it is designed to close easily, and this has unfortunate implications for the respiratory tract in some pathological conditions. Obtundation of consciousness from any cause will depress both the pyramidal and extrapyramidal motor functions, and the inevitable consequence in many patients is upper airway obstruction. Examples of such conditions are head injury, stroke, seizure, and the post-ictal phase of seizures. Intoxications such as drugs, especially recreational drugs, or alcohol. Meningitis. Encephalopathies such as preeclamptic, hypertensive, and hepatic encephalopathy. We must recognize that all central depressants, whether they be sedatives or general anesthetics, can cause or worsen upper airway obstruction, and they do this in a dose-related manner. Again, general anesthesia and any sedative agent can obtund consciousness, and as a patient becomes unconscious, three things happen in a predictable sequence. First, the upper airway relaxes and closes, which we call loss of the airway. Then, the patient may develop apnea, and at deeper levels of anesthesia, there may be circulatory instability. If we have given a sedative or general anesthetic and the airway has closed directly as a result of our actions, then we must have the skills to fix the damage we've caused, and we must have the skills to open the upper airway. And this responsibility lies with me. It is my job to fix these problems, the problems that I have caused, because I am an anesthesiologist, and quite simply, the essential skills of the anesthesiologist are my credentials for teaching you this subject. Look at these very interesting images. The first shows the position of the tongue and the posterior pharyngeal wall in a normal position, with the upper airway, although narrow, being completely open. This is equivalent to that 4 millimeter gap in the midline that we saw on the cross-sectional CT scans at the level of the back of the tongue. The second image shows the effect of anesthesia with posterior movement of the tongue and anterior movement of the pharyngeal wall. Again, recognize that a very small decrease in linear dimensions generates a dramatic decrease in cross-sectional area of the airway. A common and recurring theme in my airway management lectures is the ability to create a corridor from the patient's mouth to his or her larynx. If you can create a corridor from the patient's mouth to the larynx, then this allows you to push gas down it towards the larynx. That is, you can perform manual ventilation. Also, I refer to this sometimes as mask ventilation, but the two terms are synonymous. Further, if you can ventilate down it, then you can look down this corridor to intubate the larynx, or you can pass a bronchoscope through it if you need to use that technique to intubate the larynx. So, how do we open a closed airway? So how do we create this open corridor from mouth to larynx? How to open a closed airway and to ventilate a patient or even intubate the patient is the subject of the next two video presentations in this series. You now have the required information to understand the physiology of the airway, and we can put this into practice in learning important interventions to manage the airway. So thank you very much for listening. This is the end of this presentation on upper airway physiology. Remember, in the practice of anesthesia in general, and airway management specifically, knowledge is power.